This is the presentation on the Well Child visit for school-age children, and it might be more useful for you to actually listen to the presentation on attention deficit hyperactivity disorder, which is in the mental health module, before you do this module, because our first case study is a school-age child who comes in for attention deficit or for a sports physical, but actually has a past history for attention deficit hyperactivity disorder. So I suggest you pause this one and go into the mental health module and do the ADHD prior to this, just to make the case more fun. But here we go. So Adam is a 9-year-old, and this is not his real name and not his real picture, being seen in your clinic, and obviously he's based on some of my clinical experience in Sheridan. His history is significant for attention deficit hyperactivity disorder. He's been on Ritalin for the past 8 months. His parent states that he successfully completed 4th grade. His weight today is at the 90th percentile and his height is at the 40th percentile. His parent states that he's been lying to her on a number of occasions and has been difficult to discipline at home. And the mother has tried spanking, but he seems to be repeating the same behaviors. So what additional history would be helpful for you in counseling this mother about Adam? Well, we're going to start with the interim history like we always do. And the interim history involves interviewing the child to establish rapport, interviewing the parent to gain their trust, and really you can see bright futures for the specific questions for each age. But we really add school readiness and school performance to the school age visits. So Adam's history, the teacher completes an interim evaluation of his ADHD, the parent evaluation of ADHD. We want to pay attention to his appetite and his weight, because we know the effects of Ritalin can decrease appetite and sometimes the child will lose weight. We also are going to key into the discipline strategies being used and their success, and of course his immunizations, just to review if he's up to date. So what particular areas of the physical exam are important to assess? And what change on physical exam do you expect to change at this age? Well, we're going to look at the vital signs, and as we have discussed with each age group, as the child grows bigger, the organs grow, and that will affect blood pressure and pulse. Blood pressure goes up, pulse goes down. BMI percentile, we want to calculate. Now, I told you his height and weight percentile, but BMI percentile is going to be important for assessing whether he's overweight or obese. And those are obviously an issue for this young man, and we also would worry about BMI percentile then. And the BMI percentile is based on the gender, height, and age, and using the NHLBI guidelines and those specific charts to assess his blood pressure percentile. And then you're going to do a head-to-toe assessment. So physical changes, we expect steady growth. Weight should increase about 3 to 3.5 kilos per year. The height should increase about 6 centimeters per year. And once again, it's imperative that you calculate the BMI and plot it on the growth chart to obtain the BMI percentile. In normal development of school-age kids, there should be a decrease in body fat, but as we're seeing more and more children with obesity, that becomes an issue. And then there's increased organ development, which we've already mentioned. And we expect their spine to be straight. We want to evaluate for any scoliosis. And certainly, if there's a significant degree of curvature of the spine, they need to be referred. And at this point, the legs should be straight. Remember in our preschoolers, we said they developmentally may be a little knock-kneed, the genu valgum. But if that persists into school age, they should be referred to ortho. There's also some other physical changes that we expect in the school-age child, and their vision should be 20/20 by the age of 7. Their tonsils and adenoids remain very large and hyperactive, and it's extremely common for them to have very big tonsils, and it may take a while for them to resolve after a pharyngitis. We want to do a speech assessment and refer if they're not fluent. Their enunciation usually improves with jingles and whistling. But if it persists that they're having dysfluency or speech impediments, they should be referred. The child will lose their baby teeth and get permanent teeth, and an orthodontist referral for malocclusion should occur by age 10. The other thing we want to start evaluating in the school-age child is the presence of the secondary sexual characteristics. And I just want to review sort of what happens developmentally. With the males, they usually hit a growth spurt somewhere around 10.5 to 13.5. They kind of shoot up in height. And you'll also notice that they'll have the first signs of development in the males are increased volume, testicular volume. And that usually happens in most boys between 9.5 and 13.5 years. Then around 11 to 13, somewhere in there, they'll develop axillary hair. Shortly after that, pubic hair. And somewhere along the line of 11 to 14, they'll have facial hair. In females, the growth spurt sometimes happens a little bit sooner, but the range is still 10.5 to 13.5. And breast development begins anywhere between 8 years and 13 years. We're seeing earlier development, especially in children who are overweight. With the increased production of hormones from the fat cells, we're seeing secondary sexual characteristics occurring earlier, especially in those overweight children. Menses starts between 10 and 16 years in most girls. Axillary hair appears between 11 and 13, and pubic hair sometime between 10 to 12. So we really want to do the assessment of Tanner staging and document that in the school-age kid. So physical development, we want to pay attention to the neurodevelopment, and that includes all the things that we've been assessing all along, you know, the gross motor, fine motor, language, and social. And pay attention to what the developmental theorists have to say about this age group related to cognitive, psychosocial, emotional, and moral development. So let's review what Piaget had to say about the cognitive development. School-age kids are in this period of concrete operations early in the school-age period, with some logical reasoning developing, perspective taking developing. They are a little less egocentric and begin to be able to consider multiple aspects at the same time. And they begin to develop some problem solving, understanding concepts of reversibility and conservation and seriation, putting things in order and classifying things into groups. The concrete operations, performing mental operations occurs where they're able to add and subtract and start to create maps. They understand the serial relationships so they can order pictures or understand number concepts. And the classification is necessary for them to begin the decoding tasks that are associated with reading, and also classifying. They like collecting things. So whether it's collecting stamps or coins, or at one point it was Pokemon cards. That you know, children have a variety of things that they get fascinated with collecting, but that's all part of the cognitive development and this concrete operations. And then they begin to develop the ability to make some judgments. This teacher is strict but fair. The immunization shot will hurt, but it will help me so I won't get sick. And the other thing that happens is they're able to kind of begin to plan and organize their behavior, and their self-control increases and their self-regulation improves. There should be a decreased impulsivity in the school-age child, and if you're not seeing that, those are the kids who need to be evaluated for ADHD. We do know that achievement in 3rd grade correlates highly with achievement measures at the 12th grade level, and in some cases, there's such a strong correlation with their later achievement and actually productivity into adulthood that some states use 3rd grade achievement to predict how many gel cells they'll need down the road when these kids become adults. Erikson talks about psychosocial development, and the kids are really leaving this initiative versus guilt that we saw in the preschooler, and entering the industry versus inferiority, and they're internally motivated to achieve and compete and obtain recognition, and they're really eager to learn. So they need to be encouraged and praised for their attempts rather than belittled for not being perfect. And kids will develop feelings of inferiority or sense of failure and lose their interest in learning if they're not given the appropriate encouragement. So how would you assess Adam's emotional development, and what parenting advice do you have for the parents? Think back to Adam, who was our 9-year-old. He's having some problems with ADHD. He has now successfully completed 4th grade, seems to be doing a little better on his Ritalin. And mom is worried about his lying on a number of occasions. And she's had difficulty disciplining him, tried spanking him, but he seems to be repeating the same behaviors. So what do you think? So we'll talk about some of this in some detail, but his ADHD, kids with ADHD are aware that they're struggling with their behaviors, and they don't want to be impulsive, but they are. And the fact that he's now been more successful in school will help his emotional development, but these behaviors and his parenting with his spanking are sort of problematic. So mom needs to be reassured that the lying behavior is very common for school-age kids, and that it's important not to set him up. If she knows he did something, don't ask him if he did it, but rather say, I know you did this, and I know you know it's wrong. What do you think the punishment should be? And then we'll talk some more about this, but Corporal punishment is linked to aggressive behavior in children and not improving any of the behaviors, so is not considered a good discipline strategy in this age. And withholding privileges or giving additional chores or something like that is a better strategy. So for self-esteem, self-esteem's identified or developed by how the child is treated. So the actual words are less important than the judgments that accompany them. So if the parent is frustrated and spanking the child begins to have very low self-esteem, where if the child is treated as though you're still worthy, but your behavior was not acceptable, and here's the consequences of the unacceptable behavior because I know you can do better. We know that the children who have decreased self-respect will become more defensive around their weaknesses and not around their strength and adequacy. And so once again, it's really important to catch something the child is doing well, and the suggestions are to have a 3-to-1 ratio around that. So try to catch the child doing something positive or some strengths before you talk about the weaknesses, and 3 strengths with 1 weakness. And then we also know kids will hide their feelings of worthlessness, and sometimes that comes out as aggressive or bravado. And we have to encourage parents to be really careful with impossible demands or expecting perfection, because that really equates with developing low self-esteem. And then the self-esteem building really focuses on behaviors, not the child. So parenting strategies to promote emotional health are focused around these principles of focused attention on the child, direct involvement, demonstrating love and acceptance, and emotional presence. So as we think about the school-age child and the kid at 4.5 to 7 years, they still think, they're still pretty egocentric, and they think the world kind of evolves around them. And there's this sense of grandeur and omnipotence, and they think they're the best at everything, and they are center stage, and they have this active fantasy life, and there's all this curiosity and expressiveness. And that's just normal developmentally. Then, as the child begins to get a little bit older, the 8 to 10-year-old, the world is about other kids and their peers, and they move from the family-centeredness into the peer relationship-centered. And it's a little more reality-based than fantasy. They may identify with the same-sex parent and have goals related to career, related to being male or female, or identifying with a family member. I want to be a policeman, or self-image being defined by the peer group. There develops at this point a pecking order on the playground, and it's important to identify if there's any bullying or inappropriate behavior going on in the peer group. The third stage then is the world is inside me, and as they get to the preteen years, the 11 to 12-year-olds begin to integrate values and ideals based on who they feel they are as a person, and they embrace their beliefs and develop internal values. So I want to be a good student, I don't want to be mean. They begin to focus on the physical changes, and that really becomes most important in the adolescence. So going back to Adam, what do you think about his lying behavior, and what parenting advice do you have for the parents? As I mentioned previously, lying in the school-age child is really common, and as we think about this particular case, we want to give the parents the strategies of not setting him up for lying if we know he's done something, not to ask if he did it, and give him the opportunity to lie. And also the more positive parenting to support the child's development. So let's talk some more about that. So here's some steps that are encouraged for parents to develop more positive development in kids. And one is floor time, unstructured time to set aside for yourself and the child to build this good relationship with shared attention and interaction and communication with the child. And the suggestions are 30 minutes per day, and the child really directs the activities. So if the child has an interest in reading or music or taking a walk or playing basketball, the child gets to pick what those 30 minutes look like. And then the parent interaction really supports the child and listens and picks up on cues. Step 2 is problem-solving time, and the child is an equal partner with the parent, and the goal is to learn to be logical in their interactions, anticipate and solve challenges, and grow intellectually and emotionally. An example of that can be, the teacher said you lied about Johnny taking your assignment, so there needs to be a consequence. What do you think the consequence should be? Step 3 then is identify and empathize with the child's point of view. So empathize with the child that their feelings, goals, or reasons for the behavior. It's easier to work on changing behavior if you understand what their goals were. And you empathize, you don't criticize, but empathy doesn't mean you agree or accept the unacceptable behavior. It means you listen without getting defensive. So I understand why you lied about turning in your assignment, because you didn't want to get it in trouble and you really want to be a good student and you want your teacher to like you. I get that, but we can't be telling things that aren't true. So step 4 is the problem solving, and it involves small steps to allow the kid to kind of master these problems and feel successful. So you want them to achieve success at each little step so they gain that confidence to keep going. So here's a school-age boy who's feeling overwhelmed by schoolwork, and the steps could be to separate the school topics, identify the work associated with each, identify a work schedule, identify the support he needs, and break it into a timeline that's manageable for him. And then step 5 is the setting limits. So you provide structure, you set the limits, you pick your battles, and you discuss the large categories. So respecting others, no physical violence, consequences that matter to the kid are most effective. So it may be TV, computer games, earlier bedtime, losing specific toys. And when you increase the limits, you increase the floor time to provide more empathy and more positive reinforcement and reminders about the unacceptable behavior. And don't limit social situations. That tends to backfire. So when we remember Kohlberg's moral development, and remember that he applied Piaget's theory of cognitive development to the development of moral thinking, and this school-age group starts as concrete and egocentric thinkers, and they gain the cognitive reorganization. So the ability to see things from another's perspective should develop. So when we talk about Kohlberg, the stages that emerge from thinking about moral problems, the social experience stimulates our mental processes. So change occurs when they can do role-taking opportunities to consider the other's view, and coordinating cooperative activities. So those are all strategies parents can use. The pre-conventional morality, the stage 1, is obedience and punishment, and we've talked about this before, that pre-operational and concrete operational. So the child assumes that the authority will set the rules, which must be obeyed without questioning, and the child responds because of the fear of consequences, and there's concern with authorities and punishment, and the child sees morality as external to themselves. So the pre-conventional morality, stage 2, is the individualism and exchange, and corresponds with Piaget's concrete operation stage. So the child recognizes that there's not one right view, there might be multiple perspectives, and everyone pursues their own interests, and that punishment is a risk that one wants to avoid. There should be a fair exchange and fair deals, returning favors, and you can speak as an individual rather than as a member of society. Then there's level 2, the conventional morality, and that's stage 3 in it's good interpersonal relationships. It's kind of 9 to 20, so it's a big span. People should live up to the expectations of the family and community and behave in good ways. And then there's stage 4, maintaining the social order. People become concerned with society as a whole, and the emphasis is on obeying laws and respecting authority, performing one's duties so that the social order is maintained, and you become a good citizen. So level 3 is the post-conventional morality, and that usually happens in young adulthood, but might not ever be attained in some of our populations. Principled decision-making based on universal standards and not dependent on culture. So when we think about school-age children's morality, 70% of 7-year-olds are in stage 1, and they're still following rules because they fear punishment. By age 12, about a third have advanced to stage 4 and really understand maintaining the social order. And then remember what Carol Gilligan said about moral development in girls, that it's a little bit different perspective, and that females, she developed this concern when females scored lower or less developed in Kohlberg's investigation. And she really criticized Freud and Erikson's theories because they talked about women being stunted because they stayed attached to their mothers and families. And Gilligan asserted that women were not inferior, just different. And she has stages as well. She really focused on girls' differences being on the rules of the game, but on the not focusing on the rules of the game, but on caring things to do, and girls focusing on connections among people rather than separation, and this ethic of care rather than the ethic of justice. So her pre-conventional phase, the goal was individual survival, was a selfish stage, transition for selfishness to responsibility occurred, and then in the stage 2, which was conventional, the goal was self-sacrifice is goodness and care for others, equating concern for herself with selfishness. And then 3, post-conventional goal was concern for others and connecting relationships, and ignoring your own interests might harm the relationship. So the principle of responsibility and nonviolence and not hurting others was paramount in this phase. Robert Coles then talked about the moral intelligence of children, and he talked about the elementary school years as the age of conscience, and character is built and consolidated, and conscience really was equal to the voice within us that had heard the voice of others, starting with parents, and guided our thinking and doing, and then the individual child develops their opinion. And they have choices and options from the outside influences, and that mixed moral messages can confuse these kids and really can cause problems. He also talked about the moral intelligence in school-age child, that they needed help with differentiating and deciphering good and bad behavior, what is acceptable, what is not permitted, and what is totally out of bounds. And that moral moments happen throughout the child's life, and those can be learning opportunities when the adult can make observations and educate the kid about the world. and that children get values education or character education formally and informally in the home, and that they live and learn by example. And that needs to be reinforced to parents at the well-child visit. So back to Adam here. He is for his well-child visit. He was 9 years old again. So what are the appropriate screening tests and what are the expected immunizations? So you know that Bright Futures has updated the periodicity table, and that can be downloaded from the website, or you may have gotten it in your package of materials if you bought the Bright Futures book. But it is available at brightfutures.org and has been recently updated. So we know that school-age kids need vision and hearing, lead if previously unscreened. Anemia is usually routinely screened for in the early school age and in adolescence. If the kid is overweight or obese, their BMI is at 85th percentile or above, they should get a lipid panel. No longer does the child have to be fasting for this really screening of school-age kids, because we found that it was impossible to get them to come back for the lipid panel if they weren't fasting. So now the recommendation is to draw it, and if it's abnormal, have them repeat with a fasting. The BMI greater than the 85th and additional risk factors, or a BMI at the 95th or above, you're going to get that same lipid panel, but you're going to add the fasting glucose, the AST and the ALT, your liver profile as well. And then if those risk factors that you're looking for are a family history of diabetes mellitus, hypertension, acanthosis nigricans, the darkening or thickening around the neck in the axilla, an increased central adiposity, and any at-risk minority groups. There's controversy around whether or not to get the urinalysis screening in school-age kids, and you will decide in your practice whether that's worth it or not, especially for sports physicals. The increased physical activity can cause some byproducts of muscle breakdown to be present in the urine, and then what are you going to do with that abnormal? So at Sheridan, we don't routinely do urinalysis for a sports physical unless the kid is sexually active, and then we are routinely screening for STIs. The PPD is indicated if there's been exposure to TB, abnormal chest x-ray, travel to high prevalence areas if this family's homeless, recently immigrated from an at-risk area, or there's a HIV infection. Immunizations, typically the 4 to 6-year-olds get a DPT number 5, an IPV number 4, influenza, MMR, varicella, Hep A if they haven't already gotten 2, and then the high-risk kids, the pneumococcal and the meningococcal. And again, stay up to date on the recommendations around those, because things are changing all the time, and it's very likely the recommendations around those may change, and there is some consideration of recommending a 3rd MMR. So parents can help with the tasks of school-age children by encouraging the kid to join constructive groups, actively supporting the groups they enjoy, offering opportunities for developing new skills, make home available to friends, and avoid giving so many home responsibilities that they don't have time for their friends, and avoid making them feel guilty when there's time away from home. So the anticipatory guidance give the kid responsibilities, reasonable chores that they can do successfully and feel good about, organize the activities around outside the home, encouraging the development of individual interests and abilities, providing opportunities for regular physical activity with something the kid enjoys doing, and don't over or under schedule the kid. We also want to talk with the families about exposure to violence and sexually inappropriate materials, limit recreational screen time to 1 to 2 hours per day, promote social acceptance, and help the child develop reading social cues, regular time and place for homework, nutritious snacks, discuss ways to discourage smoking behavior, and then prevention of safety-related, seatbelts, swimming safety, firearms in the home. That's the most common cause of mortality and morbidity of school-age children. So if they have a firearm in the home, it's locked up and ammunition is kept away and unloaded and all that. Helmets should be encouraged for bikes, inline skating, skateboards, snowboarding, skiing, all that. The other issue that comes up a lot in school-age children is the bullying behavior. So I just want to spend a couple minutes talking a little bit about the difference between teasing and bullying, and then some strategies for dealing with it if the family's encountering this. So teasing is expected and normal, and it's joking around, making faces, playing games such as keep away. It is light and the intention is fun. Bullying, the intention is malicious, and it's deliberately provoking negative reactions. So denigrating or humiliating another child, it's mean-spirited, it can be emotional or physical, intended to instill fear or make the child feel bad about themselves. The risk factors are a child who's shy, lacking close friends, overprotective parents, a family in crisis, if they're different in any way, if it's a different racial or ethnic background, or kids with special needs or disabilities, and any provocative or inappropriate behavior. So the child victim, 1 in 10 kids are victims of bullying. They have more physical complaints such as headaches, stomach aches, mouth sores. They're depressed or have thoughts of suicide. They have school refusal or social avoidance, and sleep disturbances. So profile of bullies, they're frequently verbalizing threats. They're 6 to 8 times more likely to hit back when hit. They have poor self-esteem. They have aggressive behavior. They have usually poor school performance. They may have some substance use, and many times result in long-term unemployment. They lack impulse control. They watch violent TV, movies, video games, and females look a little different. So girls fight with body language and relationships, and more cyberbullying. Aggression is most often non-physical, indirect, and covert. So it may be internet, telephone, talking about one another, exclusion, rumors, name-calling, and manipulation are more common bullying behaviors in girls. There is some evidence to suggest some school-based programs, such as the OLWEAS program, which there's been several publications on, and the principles of the bully-proofing schools is no bullies, no victims, and no bystanders. So everybody plays a role. And so recommendations for parents include asking the child about unusual behavior, bruises, or torn clothing. Show concern and plan to help. Everything's not fine if the kid's being bullied. Ignoring the problem does not make it go away. It needs to be addressed. And any decreased school performance should be explored, because that can be a key indicator. And together with the child, you need to develop a plan of action, find out what the school is doing and what they're aware of, learn more about the kid's social network, and help the kid develop some of assertiveness skills and social competency. The OLWEAS work has suggested that developing a sense of humor around trying change the bullying behavior into a teasing situation, so using a sense of humor, and then not being very firm about not being a victim. And then you also want to help the child instill pride in what they're accomplishing and not feel inferior. Now, they can also work with the child on role-playing responses to bullies and encourage participation in more positive social groups, and linking the child with something that they're good at, where they can contribute and be valued more than the group that's bullying them. And then invite friends to the house, take them out on outings, and build their confidence through after-school activities that they're good at. For parents of the bully, aggressive behavior is often learned, so it's talking about, have they witnessed these kind of behaviors at home, or have they experienced themselves with an older sibling? Listen when the teachers say a child is aggressive. It needs to be addressed, even though it might not be what the parent wants to hear about their child. Compare the school reports to behavior with siblings or behavior they've witnessed at home. Limit their exposure to violent media and messages. Make it clear that hurting people physically or emotionally is not okay. And increase recreational time as a family. And sometimes these families need referral for counseling. So you want to eliminate physical punishment. As I've mentioned before, corporal punishment is associated with increased aggressive behavior in the child who experiences corporal punishment. So hitting, spanking is not effective. And you want to forbid verbal cruelty and teach steps to deal with anxiety or frustration. So counting backwards, taking deep breaths, removing yourself, walking away, encouraging a sense of empathy and helping the child discuss how aggressive behavior affects others, and praise for any positive behavior, and make 3 positive comments for every criticism this child is given. And as I mentioned, these families frequently need to get some mental health referral for some additional strategies to cope with these children. The earlier it's caught and addressed, the better. So let's talk a little bit about another problem that we see very frequently in school-age child, and sometimes can be associated with this bullying behavior, and that's school phobia or social phobia. And it's a form of anxiety. The symptoms include stomach aches, headaches, nausea, vomiting, diarrhea, being more tired, dizzy, pale, or unable to sleep. And it occurs in the morning, worse at the time of departure for school. Symptoms are gone on the weekends or at the end of the day. And the timing of the symptoms can be your major clue to this being a phobia. We know that 5% of elementary school children and 2% of middle school kids develop school phobia. And they're usually good students, well-behaved. Girls outnumber the boys. There's persistence of this separation anxiety. Parents are usually loving, conscientious, have a close relationship with the kid, and the child feels more comfortable staying home than addressing these stresses at school. And then there's the secondary gain of attention that gains or encourages the behavior to continue. Precipitating events can be things like change in school, family stress, travel stress, academic stress. Overachievers many times will have more of this school phobia. And if there's any stress going on in the school, if there's emotional abuse or strict discipline by a teacher or authority figure or a classmate, it can precipitate this. So there's 10 steps in convincing parents of school refusal, and that is a diagnosis of exclusion. So you complete the history, a comprehensive physical exam, and tell the parents the diagnosis after evaluation is complete, and emphasize that the kid's excellent physical condition, explain to them what school refusal is and that emotions can cause these physical symptoms, sometimes very severe. Reassure the parents about any specific diagnosis they fear, and be real clear that school refusal occurs in normal children and that you should reassure the parents that together you will treat this condition. The solution to school phobia is returning to school. Attendance is non-negotiable. Daily school attendance will lessen their physical symptoms. And be firm but not angry. On school mornings, the rule is to allow the child to be at home will make things worse, and you want to enlist help from the school officials if the child becomes unmanageable and won't get off the school bus. Child comes to the mental health care provider any day she stays home. They see if the child can identify fears or discomforts and encourage the child to spend time with peers. If this is bad, really extreme, they may need referral to a mental health provider, but usually the school avoidance can be managed by the primary care provider. Referral is required if there's any psychotic children, depressed children, children incapacitated with fear and anxiety, or a symbiotic parent-child relationship where the parent and child can't separate. So what are the common causes of school failure in school-age children? It's 10 to 15% emotional disturbances, 5 to 15% that attention deficit disorder, 7 to 10% will have a learning disability. Mental impairment is only 2 to 3%, and chronic illness is 5%. Then there's a few other ill-defined factors that can contribute. So what's the pathogenesis of learning disorders? There's internal factors like hereditary, developmental variations, the central nervous system immaturity, chromosomal disorders, pre- and perinatal insults to the central nervous system and prematurity and its complications. The external factors can be things like language dysfunction, social, cultural deprivation, toxins, both prenatal and postnatal, or in the environment, like lead poisoning, and then central nervous system infections and trauma. So areas where learning challenges may occur is taking in the information, processing the information, or communicating back. There's All Kinds of Minds Institute, and the link is there for you. These are good resources for parents. It's a nonprofit institute that develops products and programs to help parents, teachers, and clinicians. And it helps children address their differences in learning style. Here's some additional resources and web links that may also be beneficial for these families. And then there's some websites for resources for ADHD. So now I want to move to some common complaints, physical complaints or conditions that occur in school-age kids and may come up at the well child visit. Primary nocturnal enuresis is one of those, and over 50% of kids who have bedwetting problems have a first-degree relative that have wet the bed, and it's autosomal dominant. It is chromosomes 8, 12, 13, and 22 that have been identified that contribute, and it's clinically and genetically heterogeneous. And primary nocturnal enuresis is defined as a kid who's never been dry at night. If it's secondary, you want to rule out infections or stresses or traumas or something like that. But primary nocturnal enuresis is never been dry at night. The epidemiology is that by age 5 years, about a quarter of children have nocturnal enuresis, 20% at age 7, 4% at 10, and unfortunately 1 to 2% of kids will persist until the age of 18 and older, and it is more common in males. The differential diagnosis for primary nocturnal enuresis, which we said is ongoing wetness, it's not a new problem. So the differential is this idiopathic? Is it a disorder of sleep arousal, nocturnal polyuria, small bladder? Is it urge syndrome, a dysfunctional voiding? Is it cystitis, constipation, psychological, neurogenic bladder, urethral obstruction, diabetes insipidus, ectopic ureter? So those are the things that you have to consider. Your evaluation is going to be a urine dipstick and culture and sensitivity, especially if this is a new onset problem. You're going to do a history and a rectal exam. If there's a history of any constipation going along with this, it could be that dysfunctional voiding from the constipation. You want to check the spinal cord for any injury, visualize the opening. You may get a specific gravity on the first morning void or a VCUG if they've had repeated urinary tract infections. So causes of secondary nocturnal enuresis are they were dry for 6 months or more, and then they begin to have bedwetting. And those are things that you'll be considering: the idiopathic, the urge syndrome, the cystitis, the psychological, the obstructive sleep apnea, constipation, acquired neurogenic bladder, acquired urethral obstruction, seizure disorder, diabetes mellitus, or diabetes insipidus. And occasionally you could have a child with a heart block that causes these symptoms, or hypothyroidism. So how are you going to make the diagnosis and differentiate primary versus secondary? Careful physical examination, careful history too, careful physical exam, urinalysis, explain away the fears, explain why wetting is not due to a structural or other problem, explain why x-rays and tests are not needed at this time. If it's primary enuresis and the child has never been dry at night, a comprehensive workup is not needed. And the most important reason to treat is to minimize the embarrassment and the anxiety. There is no role for punishment, reassurance and education, and letting the families know they'll outgrow this. So management techniques for the first month is to increase the encouragement of frequent urination and holding the urine during the day to increase the volume that the bladder can hold, and then take time to empty completely the bladder, and then be sure to reduce the likelihood of any chemical irritation, and then 8 ounces of fluid with dinner, and then withhold fluids after dinner, and have the kid empty their bladder and provide adequate sleep time for their age. Take them to the bathroom to void prior to bedtime, and then 2 hours to 4 hours into sleep. So usually for the younger school-age child, if you limit fluids after dinner, have them empty their bladder before bedtime, and then before the parents go to bed, have them get up and empty their bladder again. Full wakefulness is not necessary. They just have to empty their bladder. And if that doesn't work, you can add the alarm therapy. And most kids who have alarm therapy will improve in 2 weeks to a few months. And they just really sort of have nocturia and get up and go to the bathroom, but will stay dry. And it's successful in about 2/3 of kids. For the families who want pharmacological therapy, you can use DDAVP. It's got up to 50% success rate. It decreases nocturnal production of urine. It's available in both a tablet and nasal spray that's administered at bedtime. And there's immediate action, so it's real useful for like use at sleepovers or camp. You do need to monitor serum electrolytes. The problems with DAVP are the child can develop water intoxication and develop a headache, nausea, vomiting, and it occurs with increased nighttime intake of fluids. So you want to be careful there. You want to, again, limit fluids to 8 ounces at dinner and nothing to drink 2 hours prior to bed. The most worrisome use of DDAVP from my perspective is it doesn't change anything. It doesn't cure the problem. It just treats the symptoms. So this is not going to go away, and they have to still have the same amount of time to outgrow it. So it doesn't cure it. It just treats symptoms. There's other medications that have been tried. Ditropan, if they're actually having bladder spasms, can be helpful. And depending on the child's degree of symptoms, you can try these other medications. But again, it doesn't treat the problem, just treats the symptoms. Imipramine is a tricyclic antidepressant, results in dryness in less than 50%. Relapse rate, again, is high as soon as you stop taking the medication. And side effects can be the irritability, drowsiness, constipation, and reduced appetite with personality changes. The World Health Organization does not recommend it. And what we know is prognosis is good for these kids. There's going to be a spontaneous cure rate for children who are not treated, and it's about 15% per year. The DDAVP results in total dryness in about half of the kids with improvement in 75%, but as soon as you remove the therapy, most often results in a relapse. And so really helping the families manage the symptoms without medication, I think, is preferable. Here are some resources, and I know you will see this in school-age children. It is a common concern, and reassurance and some strategies for dealing with the problem is the best help for families. So I think you're pretty prepared to tackle the common things you'll see in school-age well child visits, and I hope you have fun seeing these kids.